Okay, let's move on now and talk about something different. I'd like to talk about fast heart rhythms that are dangerous. So, if you watch any kind of TV medical drama, there's, they call the code blue, and they show the monitor. They call it flatline, but it's kind of wavy. And then everybody runs in the room, and they get out the paddles, and they put the paddles on. And they call clear, and they shock the patient. The patient jerks up, and if things go well, the patient wakes up. So that's called defibrillation. Now, in the real world, we actually do that. It's not typically as dramatic as what you see on TV, but that is a real process. When the heart becomes unstable and stops beating, generally what happens is instead of going to completely flat and not beating at all, it goes into a quivering. So essentially the heart goes from being very organized and squeezing to being disorganized and squeezing. And when it quivers, it doesn't pump blood. Now that is an absolutely life-threatening process. And if it happens and the heart is not treated very quickly, people just flat out don't survive that. So my job as a doctor is to try to prevent that from ever happening, and in people in whom we can't prevent that from ever happening, to be there to be able to fix that if it ever does happen. And that's where the implantable defibrillator comes in. These were developed in the late 80s and became kind of a real-world device in the early to mid-90s. And they're a device similar to the pacemakers, implanted inside the body through the veins, and their job is to sit and watch the heart at all times, and if the heart should ever stop, to be able to fix that. And it typically fixes it by delivering a shock similar to what you see on TV, but all done inside automatically, not quite as dramatically. So let's talk about how that's done. So here's our heart again. The typical patient that is at risk for cardiac arrest has some type of a muscle disease of their ventricles. Now, there's a lot of reasons why this can happen, but the typical patient we see might be somebody who's had a heart attack. So let's say years ago, this part of the heart lost its blood supply and went from muscle to scar. That part of the heart doesn't squeeze, and it reduces the pumping ability of the heart. But in addition to that, it also sets up little electrical short circuits in the heart, which might be the area where electrical impulses go awry. So recall, the normal way for the heart to squeeze is the top chamber gets electricity from its natural pacemaker and then travels into the bottom chambers, and that sequence repeats itself about once a second. Sometimes what will happen, and it can be kind of a random process, and sometimes it's because of, again, problems with blood flow or electrolytes, blood chemistries and such, but this area can get irritable and start sending out erratic impulses where the electricity is spinning out of control down here. That emanates out into the rest of the heart. It takes over, and now the bottom chamber of the heart, instead of having a nice organized contraction, goes into this quivering process. The only way to treat a sustained quivering, or what we call fibrillation in the bottom chambers, is to shock the heart. And when you shock the heart, the way I think of it at least, what you do is you apply a high energy electrical signal to the heart. The whole heart squeezes in response to that, and that kind of resets everything. Now everybody's on the same page, nobody's listening to the quivering anymore, and if things go well, you take right back over, the top chamber fires and the bottom chambers follow in response to that. And if you get to somebody early and when their heart's fibrillating, you can generally turn them around very quickly. Now, in the hospital, I'll often tell my patients, if they're sitting with me, I say, if this happens to you right now, I'm going to run out there, I'm going to get a defibrillator, we'll turn you right around. Now, if this same thing happens to you in your home, you're going to have to be very, very lucky. Someone will have to be with you to call 911, do CPR, while the squad's driving in, and then they have to get to you, get the paddles on you, and convert you. And for every second or minute that you're not converted, the likelihood you're going to pull through this is much less. So the purpose of the implantable defibrillator is essentially to have a paramedic squad on call with you at all times, so that if this does happen to you, you'll get your treatment right away and you'll come around quickly. And that actually is what happens. They work very, very well. How do we figure out who's at risk? That's a really good question. And we think about it in the office, and we've built protocols to try to predict who's at risk, and a lot of research has been done on that. If someone has a heart attack and we get them through the heart attack, we get them we call it revascularization if they need it, open the blood vessel up, get them on all the right medications to preserve heart muscle, to try to prevent new blood clots from forming, and get them through that process. We then later, usually about 3 months or so after the heart attack, will then image the heart, usually with an echo, and see how well it's squeezing. And we measure something called the EF. Now, EF stands for ejection fraction, and it's a number that we'd like our patients to be aware of, just like they'd be aware of their cholesterol number or their blood pressure. And we'd like them to know what their EF is so that if their EF is not appropriate, then they can help us seek the right attention to take care of that. Now, EF normally, let's talk about what EF is. So if the heart squeezes, the amount of blood, proportion of blood that leaves the heart with each contraction, that's the EF. So if a heart completely emptied, that'd be 100%. Now, nobody has a 100% ejection fraction. A normal heart squeezes about 50 to 60% out. So normal is 50 to 60%. And you can pick that up. The most common test is an echocardiogram, sound wave picture of the heart. We can also do that with nuclear scanning, heart catheterization, angiogram. There's a variety of ways to get that number, MRI. If you have a heart attack, that portion of the heart doesn't squeeze, that's going to reduce the ejection fraction. If it's less than or equal to 35%, that's kind of a red flag. Research has shown for people that have ejection fractions that are 35 or less, that defibrillator implantation can save their life. And that's where the indication lies. Now, we need to make certain it's a 35% that's going to stay that way. We're going to do what we can to raise that ejection fraction. So I mentioned before, if they need revascularization, improved blood supply to the heart, stents, bypass surgery, those things are really good at raising ejection fractions. Medications like beta blockers, ACE inhibitors, ARB drugs are really good at raising ejection fraction. So until those things have failed, that's why you typically wait about 3 months, we're not going to put a defibrillator in. But if after all that's been done, the ejection fraction is still less than or equal to 35, then we're going to have a conversation. Those are the folks that often get sent to me as a consult. And I always say to them, this doesn't mean you need a defibrillator. I don't like using the word need. It just means that this is an option worth considering. We're going to look at you individually. We're going to go through the pros and cons of defibrillators. And we're only going to offer a defibrillator to you if you meet all those criteria. But even then, it's going to be your decision as a patient whether or not you want a defibrillator. I'm not going to stand over you, twist your arm, and say that you're a fool if you don't get a defibrillator. This is a big decision. So we're going to put it all out there for you. We're going to support you on whatever decision you make. But that's kind of where it goes. It's not quite as simple as just 35 equals defibrillator, but that's kind of the starting point of the conversation. So keep that number in mind. You should know what your ejection fraction is. If you have a low ejection fraction, make sure you ask your doctor, am I on all the right medications? Is the blood flowing properly through my heart? Would it be appropriate for me to meet with an electrophysiologist to talk about the option of a defibrillator? That's something that I think our patients should be empowered to know.